This conference will now be recorded.
So, good afternoon, students. Had your lunch? And now the topic is safe motherhood. I know this is one of the dry topic and boring topic. I'll try to make it simple and quick. Okay. So, what you know about safe motherhood? One of you answer me. What are the events covered under this safe motherhood? Fine. I'll move on. So, coming to the definition part. Safe motherhood is one of the most important components of reproductive health because this is one of the physiological process, pregnancy and childbirth. So there are a lot of reasons for mortality like RTAs, medical disorders, surgical disorders, but this is one of the physiological condition, and mortality due to this condition is relatively unacceptable. And also we have higher the incidence and prevalence of maternal mortality in developing countries compared to developed countries. So safe motherhood is one of the most important components of reproductive health. This is nothing but what all we can do to prevent maternal morbidity and mortality. What are all the measures we can take even before she is antenatal, during antenatal period, throughout the pregnancy, safe delivery, safe abortion practices, family planning. We advise them regarding healthy pregnancy, birth spacing, safer deliveries, institutional deliveries, and postpartum care like breastfeeding, immunization to the baby, post-abortion care, and childhood care. So these are all the events covered under this safe motherhood. So this means ensuring that all women receive the care they need to be safe and healthy throughout the pregnancy and after pregnancy and during childhood also. So it is the ability of the mother to have a safe and healthy pregnancy and childbirth. We will try to ensure that she is safe during her total starting from conception to even during adolescence also. What are all we take care about adolescent girls to prevent anemia, minor ailments, worm infestations, and we'll boost with iron supplementation perinatally also. And once she is pregnant, safer visits. How many antenatal visits she should have? She should have STT injections. She should have safer scans. If any complications are there, we must be early to pick those and make her to have a complete, good, safe delivery and healthy pregnancy, childbirth. That will be our motto. Okay. So finally, what we want is to lessen the maternal mortality. Considering the high maternal deaths in developing countries like India, WHO in 1987 conceived this idea of safe motherhood initiative at a conference which was conducted in Nairobi, Kenya. So then the concept of safe motherhood initiation was started. And what was the goal? That time, it's a global effort to reduce the maternal mortality. What is maternal death? Anything during or because of pregnancy or 42 days post-pregnancy. Mortality, all these come under maternal mortality. At least by half by 2000, and later on the goal was extended till 2015. So what are the main objectives? To enhance the quality and safety of girl and women life. So she should have proper access to healthcare. She should have proper access to education, healthcare facilities, and proper nutrition with the help of our Anganwadi workers, ANMs and all. So good quality and safety even starting from adolescence, girls to women life, through adoption of a combination of some health strategies and non-health strategies. Health strategies include all our medical care facilities and all. Non-health strategies include different schemes by the governments. So overall development of the girl and women health and well-being, that will be the main objective, and to improve the quality and increase the access to family planning and maternal care. So most of the tribal areas and all, they don't have that idea about this family planning and birth spacing. So more and more frequent pregnancies, she will be anemic, she will be having cardiac failure, maybe So grand multiparous, nowadays we are not seeing this grand multiparous. So better improve the family planning, awareness about the family planning and contraceptive methods, and maternal health care services. And next, educate the couples to ensure that they have a best chance for wanted and safe pregnancy. Compared to unplanned and unsafe pregnancy, safer pregnancy will have a better outcome. So you have to ensure the couple and educate them. You have these many options, you have better chances, and you can give about the reproductive health knowledge to them, and to promote improvement of the systems for monitoring maternal and newborn. So how can we do? Starting from PHCs, Anganwadi workers, ANMs, ASHA workers, all these, they go to doorstep of the patients also, and to monitor about their health conditions, and to improve the vaccination about the newborn babies, and to promote and implement evidence-based integrated cost-effective reproductive health. Not only the availability of medical facilities, they should be cost-effective, and they should be focused on the maternal and newborn healthcare. Now we have lot of schemes, even because of delivery, they are getting lot of incentives. They will get the transport access when she enters into labor. The government will pick the mother and attendant in their own vehicle, call it as Talibida Express. We also have that access after delivery, and after delivery also the vehicle will drop them at their home. Because she was delivered in that hospital, she will get some incentives like 6,000. So these are all the things implemented by the government to encourage safe institutional deliveries, and also uh, they can have good nutrition, and medically also they can have good proper medicines. So encourage them. We have different schemes, and to conduct operations research to generate best practices and evidence for addressing priority reproductive health problems. So all the recent advances also should be accessible to them. So these are the main objectives. So maternal death, obviously it's a global tragedy. Compared to other forms of mortality, maternal mortality is a very unacceptable thing. So globally, nearly between 15 and 49 years, that is the reproductive age group, they die every year. 6 lakh women die because of these pregnancy and childbirth and related conditions. So this is totally unacceptable and high figure. That too in developing countries, it will be more compared to developed countries, because of poorer accessibility to health services and poor knowledge and education to the women and also their families. So this means almost every minute a year there is a maternal death, and 99% of these deaths are completely from the developing countries, and majority of these deaths are preventable. So we all know what are the causes of this maternal mortality. Most of the times, if we don't pick any complications, they will lead to mortality. What can be they? Like we discussed in jaundice, acute fatty liver pregnancy, or if she's uncontrollable hypertension, uncontrolled diabetes mellitus, or she's epilepsy, she landed in eclampsia. So she landed with hemorrhage. If she's a case of placenta previa, it was not picked antenatally. She don't have any antenatal visits. Again, due to bleeding, mortality. If she is having PPH, postpartum hemorrhage, and the bleeding couldn't be controlled at their home delivery or some local dye delivery. So all these are the conditions for maternal mortality. And in India, the most common will be hemorrhage, and the second most common will be sepsis. Means unsafe deliveries, unsafe practices, no clean table, no clean scissors, no clean cord surface, everything. So not sepsis leading to septic shock is again a one more important condition for maternal mortality. All these are preventable conditions. If we take proper asepsis, if we go for proper antibiotics, if you go for safer institutional deliveries. So these are all the preventable. If we have good blood bank support, if we have good access for surgeries whenever needed compared to normal deliveries. So these are all the conditions which are preventable. In developed countries, the mortality ratio will be obviously less because they have better healthcare facilities, and it will be 8 to 17 per 1 lakh live births. In developing country, it will be 20 times higher, means 240 to 730 per 1 lakh live births. Mortality we will compare in like with 1 lakh live births. So the lifetime risk of dying from pregnancy related complications for a woman in a developing countries 1 in 75, compared to industrialized countries it is 1 in 7300. So too much high in case of developing countries. So these days the government is also more and more focusing on these maternal mortality and improving the um, condition of this pregnancy and childbirth. So what are the causes of these maternal deaths? The most common hemorrhage can be PPH, means postpartum hemorrhage after delivery, may be atonic or traumatic PPH because of untrained deliveries, or antepartum hemorrhage, maybe placenta previa or abruptio placenta, or post-abortal hemorrhage also. So these abortions play a major role, and other things, indirect causes. Next most important and common will be sepsis because of unclean and unsafe practices. Next, unsafe abortion. We have criminal abortions, unsafe abortions like RMPs, and untrained people who do unsafe abortions. Thereby, the women may land up in complications. And next comes our eclampsia. Eclampsia, you all know, if the patient lands up in convulsion, there are cardiac effects, and she may go into pulmonary edema, or she may develop disseminated intravascular coagulation, and finally she may develop HELP syndrome, and finally mortality. Next, the obstetrical labor. These days, obstetrical labor is decreasing because increased access to the healthcare facilities now also. Previous days, there is a higher incidence of obstetrical labor, and some other few direct causes account to 7% of these maternal mortality. But still, now also the most common cause is hemorrhage. So the factors for high maternal deaths, the most important maternal deaths mostly we will see in low socioeconomic status only. So low social status, girls and women, gender inequality is majorly seen in that low socioeconomic status condition. This is the fundamental determinant. So because they have limited access to economic resources, no money, so limited economic resource, less opportunity for even the basic education. Once she is educated only, she will know what she need, what are the nutrients, vitamin A supplementation, D supplementation, all these will be knowing once she is educated only. But now if she is not having even proper basic education, she won't even take care of herself. And excess physical activity, most of them will be child laborers. Physical activity and poor diet, they won't have a proper balanced nutritional diet, and less ability to take decision, unplanned childbirths. So most of the times these poor socioeconomic girls will be get married around the age of 15. They will have teenage pregnancies, more the anemia, more the complications, and more the health burden to the that little mother, and less utilization of essential obstetric service. Even if we provide the obstetric service, if they don't have the knowledge where they can get all these services, then they can't utilize it properly. Less utilization of these services. So low socioeconomic status is the one majorly facing these maternal mortality risk. And poor nutrition, poor maternal health, obviously poor pregnancy outcome, obviously poor baby health, and perinatal morbidity, mortality, and risk to the next generation baby also. And lack of skilled attendants at the time of delivery. Most of them will have home deliveries. But now people are changing, they are coming to institutions. And no appropriate referral system. They won't have, if some complication occurs, you must have a proper higher tertiary center. If problem at PHC, they can go to CHC. Next is our tertiary care center, like our hospital. So if there is no proper referral appropriate system, then also towards maternal mortality. And there, what should be there? Emergency obstetric care means they should have a anesthetic support, they have obstetrician support, they should have blood bank support, and if any complication arises, there should be some support of physician and other doctors also. So if you don't have emergency obstetric care, then sex education also plays a role, and family planning, safe abortion services. So lack of knowledge about all these and skill birth attendance again towards higher maternal deaths. So Safe Motherhood Initiative, it's a global effort, and it is designed to operate through partners. So it is divided into government agencies, non-government agencies, and other group and individuals. There will be some organizations, NGOs like that, which help in this Safe Motherhood initiative, and it aims to improve overall. Anyone's initiative is to improve women health through social, community, and economic interventions to improve their health condition by giving free medications, sharing knowledge with the help of counseling, helping them economically. So national socio-demographic goals for 2015 include these are the levels of total fertility rate. These are older figures. Actually, in 2015 it is less than 2.1, and the fertility rate now increased to 2.9. Maternal mortality ratio also it was less than 100 in case of 2015, but 254 now current level. Infant mortality is 57 now. Next, antenatal care 60%. 2015 our goal is 100. Institutional deliveries, skilled personnel. So these days these institutional deliveries increased. People are having knowledge because of these ASHA workers and all. Each ASHA worker is attached to some like 30 antenatal women. The whole antenatal women in the village should be attached to ASHA worker. So they will go each home and search for the antenatal, and they will calculate how many antenatal women there, what is the gestation, what is the care being taken. And these ASHA workers also have incentives. So because of their incentives and their salaries also, they will show interest for all these things. So Millennium Development, we all know about Millennium Development Goals. So these MDGs 4 and 5 are concerned with maternal, newborn and child health care. So what are all the reduction of maternal mortality ratio by 75% and expected annual decline in the maternal mortality ratio 5.5%. Reduction in the infant mortality below 30 per thousand live birth by the year 2015, and 90% of the all births should be assisted by skilled attendants. Access for all who need reproductive health services, and other goals include gender equality, reduction of poverty, education of girls and women. So when you happen to write about this safe motherhood, you have to write about that definition, next the common causes, and you have to include these Millennium Development Goals also. Next, so to improve maternal mortality in India, all the states have been categorized into groups. What all the states we have? They're categorized into 3 groups. First one is empowered action groups. It includes Bihar, Jharkhand, MP, Madhya Pradesh, Chhattisgarh, Orissa, Rajasthan, UP, Assam, Uttarakhand. And southern states include Andhra Pradesh, Kerala, Karnataka, Tamil Nadu, and remaining states come under Group C. So maternal mortality has decreased in 2007 to 2019. It's 212. So 2010 to 12 it is 170. It is decreasing. So the probability of dying of a woman in her reproductive age 15 to 49 years due to cause in pregnancy, childbirth, or within 6 weeks means puerperium of childbirth, all these come under lifetime risk. Presently in India it is 0.4%. Okay. So for safe motherhood we have 6 pillars. First one is family planning. Next is antenatal care. Okay. Next obstetric care. Then after delivery postnatal care or post-abortion care. Next HIV or STD control. And how will you achieve this? With the help of communication for behavior change, primary health care, and equity and education for women. So family planning, information and services to plan the timing, number and the spacing of pregnancies. So spacing is very important. So 2 closer pregnancies means the mother won't be able to rejuvenate properly, and also the nourishment of the next coming baby. If it is a cesarean section, closer pregnancy is again not advisable. Okay, so you can counsel them regarding the timing, the ideal age of having pregnancy, the ideal spacing, and the number of pregnancies. How will they know? When we counsel and approach them, then they'll have that idea. Next is antenatal care. So once she is pregnant, what care we will do? We will give routine antenatal care. Along with it, we have to counsel regarding the diet, nutrition, requirements to the mother and baby, and you have to early detect and treat if there are any complications. So to pick those complications, she must have proper antenatal visits. Next, obstetric care. Proper knowledge and equipment to birth attendants and ensure emergency care for high-risk pregnancy. So a well-equipped hospital should be there, and well-trained birth attendant should be there to deliver her. And if there is a complication or high-risk pregnancy, emergency obstetric care must also be available, or at least a referral system should be there where you have to send the patient. Otherwise, we have to lose the patient. And next, after delivery, postnatal care. It is for both mother and the baby. So for the mother, she has to recover from all those labor pain and all. You encourage her for nutrition, encourage the proper breastfeeding to the baby, and lactation assistance and family planning services. So you can advise regarding the temporary and permanent methods of contraception. And management of puerperium also, it has a lot of complications. So regarding breastfeeding or subinvolution, there are a lot of complications in puerperium. So to deal with those also, you can help the mother. And for the baby, what can you do? You can pick the neonatal jaundice, proper neonatal care, observation by pediatrician, and proper vaccination. Post-abortion care. So management of complications and family planning consultation. Illegal abortions. Illegal abortions again unsafe, but proper care after abortion. So you are checking for post-abortion bleeding, and again counseling her regarding the spacing, again when to plan the pregnancy, what are the causes of her abortion, next time what preventive measures she can take, and how can she boost up her immunity and nutritional status meanwhile. So you can take the post-abortion care, and you can take the option of family planning also. Temporary mode of contraception can be counseled to the couple. And next, our STD and HIV control. So these are transmissible, horizontally transmissible. So voluntary counseling and testing, and prevention of vertical transmission also, mother to child transmission also. So you encourage them testing and counseling for these HIV and sexually transmitted diseases. So RCH interventions for safe motherhood include antenatal care, intranatal care, and essential newborn care. Antenatally, what can we do? Early registration of pregnancy by in the first trimester itself, 12 to 14 weeks, even earlier, and a minimum of 4 antenatal visits by WHO. Means Government of India, minimum 3 visits. First at 16 weeks, second at 24 to 28 weeks, third at 32 weeks. These are, and fourth at 36 weeks should be carried, and these are minimum at least. But ideally, it should be more. Okay, every month starting from the pregnancy, and every 2 weeks after 28 weeks, and every week after 36 weeks ideally. But in remote areas and poorly developed areas, the at least minimum antenatal visits will be 4. Okay, and the risk approach to identify high risk pregnancies and labor or puerperium. So any complication or high risk you suspect, you have to strengthen the referral system also. So you should have a proper referral system where you should have proper ambulance service also, where you have to refer the high risk case, and routine immunization with TT, tetanus toxoid, and supplementary iron folic acid therapy daily for at least 100 days after the first trimester. Means daily you will take iron, folic acid supplementation, and calcium supplementation also. This is all about the antenatal care. And what about intranatal care? So institutional delivery in 80% of the cases, and 100% deliveries only by skilled persons who were trained, and should be having clean hands, clean perineal area after vaginal toileting, and clean umbilical area must be. So asepsis should be maintained. And postnatal care, support to restore the health of mother and care of newborn, family planning services to prevent unplanned pregnancy, safe abortion services, and breastfeeding, and exclusive breastfeeding for the initial 6 months to the baby, because to boost up the immunity, antibodies and all will be available in the breast milk itself. And essential newborn care, clean delivery, basic resuscitation of the baby, prevention of hypothermia. After delivery, what they will do? They will wrap the baby, clean the baby, dry the baby, and wrap in a warm towel. So why? Because to prevent hypothermia, they will apply cap also to the baby, because for antenatal fontanella there will be again loss of heat. So to prevent hypothermia, baby should be well wrapped. And prevention of infections. Breastfeeding early should be started early, and should be exclusive compared to mixed feeds and top up feeds. And 10 baby friendly hospital initiatives. And if the baby is sick or not good, then you should have a proper referral NICU setup also for the sick baby. So Women Health Millennium Development Goal beyond 2015, there is good progress has been made in achieving Millennium Development Goals MDG 4 and 5 to reduce both child and maternal mortality. But globally, it has decreased from 400 to 210 per 1 lakh live births between over a period of 20 years, 1990 to 2010. However, the progress was not that expected, fell short in case like South Asia and Sub-Saharan Africa. So only 16 countries achieved those goals, remaining are a bit beyond. So the post 2015 agenda seeks to integrate economic development. So poverty should be reduced and sustainable development goals, ensuring universal health coverage and access. So beyond these actions, good governance must also incorporate human rights, accountability, participation, ownership. So like we discussed, not only government, other organizations also should take part. And finally, poverty takes the major role to remove the poverty by providing them education and knowledge, better services available, then only economic support, these goals can be achieved. So post 2015 sustainable agenda need to consider all these issues in the international platform to achieve improved health for every woman and every child. Okay,
എന്തായാലും ചെയ്താവാം.
done. Okay guys, attendance is done, you can leave.